Okay. The objectives of this presentation are to kind of talk about cardiovascular risk factors in children, and that seems kind of a very new thing to people. Oftentimes we talk about it as an adult issue, and so why are we talking about it with kids? We're also going to talk about this project known as the Cardiac Project, what it was about, why was it developed, what did it do while it was in place. And then the last thing is we're going to talk about how we can take some things that have been in place for a long time in West Virginia or nationally that may have not been intended to better understand the same things among children with disabilities. How can we utilize those opportunities and with a slight change of focus learn more within our target area for the CED? All right, and everyone can see the slides okay? They're not too small? Okay. So cardiovascular risk factors, what are we talking about there? Basically, often related to heart disease, risk factors that increase our chance of, in adults, having strokes, heart attacks early, things of that sort, and unfortunately they are now being seen in our kids, not just in West Virginia, but internationally. So those particular risk factors that are common include overweight and obesity, and that distinction we're going to get into here a little bit, but basically for kids, they assess overweight and obesity differently than adults. So we often get this body mass index or BMI number. In kids, it's based on age and gender. There's height and weight charts that we often see as parents in well child checks. It's based on age and gender. And so their BMIs are percentiles. Overweight is anything 85th percentile and above. Obesity is anything 95th percentile and above. Okay. Other risk factors include high triglyceride levels, decreased HDL cholesterol, high blood pressure or hypertension, and then elevated blood glucose. So this is starting to get us into the type 2 diabetes and the metabolic syndrome that we're seeing in more and more of our kids, but more on the glucose and insulin side. So really any program that sets out to look at cardiovascular risk factors and try to prevent stroke and heart attack early would look at these factors. Okay, so what do we know about overweight and obesity in kids? Now, there's a slight term difference between my two slides here that I want to note. There for a while we used the overweight and obese distinction in kids. That's what we use in adults. But just recently we started to just term it all overweight because there's a huge stigma, as you can imagine, about using the word obese with kids. And so in this slide, we're going to talk about overweight and obese altogether as an overweight risk. So again, we know that we assess overweight and obesity based on percentiles, and it's important to look at that. Many parents ask about, okay, is BMI, if my doctor gives me a BMI percentile for my child, is that the best type? Probably not. It's the easiest to assess and the most accurate based on the ease, but it doesn't take into account muscle mass, so other things do. But, you know, DEXA scans and things of that sort cost a lot and they take a lot of time. So BMI is pretty accurate, give or take a few percentiles for the purpose. You know, in terms of overweight and obesity, it is an epidemic. So leads to about $127 million in hospital costs annually, and it just continues to increase over time. And that we also know that overweight or obese children tend to become overweight and obese adults. And part of that, if you think of, and we're going to talk about some of the reasons why someone becomes overweight or obese, those patterns of behavior or genetics stay with us into adulthood. So there's risks without an intervention stay with us. Okay, so in terms of some stats outside of West Virginia, so a little over 17% of kids 2 to 19 years are overweight. These trends, as I mentioned, have continued to increase over the past 15 years by about 12%. It tripled the numbers since 1980s. And that's kind of why we're starting to see and talk about these cardiovascular risks, these typically adult-type concerns in kids, because kids are having these issues. Kids have hypertension. Kids have high cholesterol, okay? And so we want to increase awareness. This, I'm sure many of you have seen this, so this is kind of how we've progressed since those 80s, and you can see it's a busy slide, but you know, the white didn't have data. We weren't even assessing that statewide. The light blues had less than 10% of kids who were overweight and obese, with the darker reds being the most, greater than or equal to 30%, a third of them. So over time, we start getting into the blues, then we get into the yellows, whereas now and even in 2017 data, primarily, except for maybe one state, all reds, and we've stayed dark red since the early 2000s, okay? So, like I said, an epidemic. So with overweight and obesity continuing to, or increasingly becoming a problem, so have these other risk factors. And triglyceride levels, and you know, as a developmental psychologist, before I started with the cardiac project, never would have asked me, it would have been dangerous to ask me about lipid values or anything like that. But triglyceride levels are really directly influenced by our diet. So you're going to see elevations in triglyceride levels perhaps before HDL and LDL levels change. Those are with over time. So healthy eating or unhealthy eating is going to affect triglyceride levels. Portion sizes, here are a few things that the physicians would talk to parents about and their kids, because really interestingly, I argued a lot that our kids are change agents, and so if they want to implement healthy things in their household, they will push us to do that, where we might be a little lazy at doing that. Marketers know this more than us. I mean, if you've gone to the grocery store, where are the sweet puffs, the Cocoa Puffs? They're at the bottom so that the kids can see them, versus the healthy parts. So we can, as parents, can focus on the food availability, you know, candy drawer, how do you look at sweets and how they're divvied out at home, portion sizes. If anyone's seen a portion size plate, we have gone way past that, no matter what type of food you're talking about. And then counteracting messages. My kids knew the golden arches before they were, I don't know. I mean, they just knew those. And again, marketing is very powerful, and they can sell things, and that can go from like Tyson chicken and, you know, different types of meat that may or may not be good for you. Instituting family meals. We've learned recently that if you sit down and have a meal without the TV or phones going on, you realize how much you're eating and when you're full. Whereas if you're not, you're distracted and you might eat more than you would. And then, of course, role models. We can serve as role models for our kids. And that's going to affect triglyceride levels. When we talk about, in a little bit, about HDL and LDL cholesterol and insulin and glucose, we're getting into the realm of type 2 diabetes. There for a while, many years ago, you only heard of type 1 diabetes, people that were diagnosed with this when they were very young. Now it's nothing to have several kids in a classroom who have type 2 diabetes. And so screening for diabetes is becoming more common among kids than it ever has before. And you can see kind of down here the ADA, American Diabetes Association, is now saying pretty much a child at 85th percentile or above, so overweight or obese, has a family history of it, which A lot of people in West Virginia, a lot of people everywhere talk about sugar. You know, they have a history of diabetes. And then certain ethnic groups are more at risk than others. So based on other risk factors, definitely recommend screening, but some people implement that. Some physicians do that regularly. Okay, hyperlipidemia is basically anything abnormal in your lipids, so HDL, LDL. And this was changed partly because of this project I'm going to talk about. There for a while it was selective screening, and now they've gone toward a more universal screening if possible, but those require resources. So definitely overweight children should be screened between 2 to 10 years. Again, more and more kids are having high cholesterol, and whether that needs to have statins or other pharmacological treatment depends, but needing to look at that is important. We're not going to get into the physiology of it, but kind of why this is all coming into place and why would a surveillance program need to look at this. So we're going to be talking about insulin, glucose values. We're not going to talk about VLDL, but the Cardiac Project did get that. They did a full lipid panel on the kids. And so basically, you know, you're at an early age just really putting a burden on the systems in the body, whether it's through diet or sedentary or a combination of both. Okay. Hypertension, the Cardiac Project started to look at blood pressures in the schools, again, late in the 90s, and from that realized that our medical students really weren't getting a lot in terms of training of getting blood pressures. Nursing students were, but not our medical students. And so you have two numbers on your blood pressure. Your systolic is the top and your diastolic is the bottom. Diastolic can be hard to hear, and so if you're in a loud school, you got to be really, really good at picking up that diastolic. And so this turned into, you know, how to do it effectively, and now our med students get it on a regular basis. So here are some of the recommendations. Screening started at 3 years, has been a recommendation of the AAP, particularly in our local chapter in West Virginia. Part of the issues that people, or the errors that people make is they'll use an adult cuff on a child, and you can't get an accurate reading. Some new cuffs have been developed for overweight or obese children because they're bigger than a child cuff, but not an adult cuff, so it's right in the middle. So companies have started to make different cuffs for accuracy. And then if you pick it up more in a child, more than likely it is hypertension. So you want to follow it. And this is just kind of one of the many flow charts that people can use. So of course, a high systolic, high diastolic, and then what level are you in based on this, and then what recommendation should you provide based on your systolic and diastolic. And again, a lot of these are modifiable lifestyle behaviors. So using less salt, being more physically active. For adults and perhaps adolescents, less alcohol consumption if the adolescent is drinking. You want to assess that. Weight loss might resolve this. And then the DASH eating plan is one that's where you can see fruits, vegetables, low on dairy, that kind of thing. All right. So again, I don't have chat up, but let me know, interrupt me if you have any questions. So the coronary, and I'm never good at naming things. I always thought this was a fantastic title. So Coronary Artery Risk Detection in Appalachian Communities for the Cardiac Project. Just fantastic. So it started, the project started, a pediatric cardiologist by the name of William Neal met a nurse from Alderson Broaddus, Valerie Miner, at some conference, And so they were saying, we need to start this. And they started, he's now a senator in collaboration with Ron Stallings. He's a senator from Boone County. And so they started in 3 counties, Boone being one of them. And they focused on 5th grade, which at the time, and unfortunately it's kind of changed, 5th grade was right before puberty. Puberty can change all of this in terms of our lipids and blood pressures and all that. So getting the kids before they hit puberty, 5th grade was the perfect option. Over the years, they added kindergarten, and that's the one I started when I started with cardiac. We added 8th grade later, 9th, and then 2nd grade came on when the governor wanted BMI assessments on most kids. And that was about the same time that all states were assessing childhood obesity among all students, okay? So I'm going to focus more on the 5th grade because the 5th grade, they're older, and the new thing, no one ever thought this would ever happen. Dr. Neal and Valerie said we're going to do fasting lipid profiles on these kids, which is a blood draw in the school, right? So you're getting parent consent to draw blood. Phlebotomists were volunteering their time to do it. It was like, you're never going to do it. And they did it. They got it. And the kids and the parents ended up using it a lot for in the place of World Child or follow-up. So because it was a lipid, it was a blood draw, it needed to be fasting. And so they did that in the mornings, and then they would give the kids breakfast after the screening. Did some kids faint? Yep. It tended to be particularly a lot of the 8th grade and 9th graders. The little ones did fine, and particularly the big guys would faint. But they had nurses there, the medical students, phlebotomists, people were there and followed up easily. So what was involved on a screening day? So about a week before the screening took place, you got this packet, this nice consent packet that ran through everything. And in there, it had a parent consent, and parental consent was required by one parent, signature. Family history was listed on there, so whether you had diabetes in your family history, whether someone has had a heart attack before the age of, 55 for men and 65 for women is the risk, and then a couple other risk factors. They would sign that, bring that back to school with the teacher's help. They'd bring the 5th grades into the cafeteria, and then they'd go through the screening day, which is height, which was all done in privacy because even now in 5th grade, they're wanting to know their weight. And so actually, we fixed that by converting the scale to kilograms, and no one knows kilograms. So they'd look at it and they wouldn't know how much they weighed, particularly the girls. So height, weight, blood pressure, then they'd take the fasting lipid blood draw, and acanthosis nigricans, or AN for short. And this is on the base of a neck. If it's prevalent, if you see it, it's on the base of the neck around your collar area, or it can be, here in the elbow, in the creases, and it's a really dark, and sometimes if it's higher levels, it can be raised skin. And that's an AN marker particularly, and then they would note the level of it. So it's really dark, pigmented, and sometimes raised. So they'd look through, they'd double check, because we're talking about kids, so they'd run their finger through just in case it was dirt and make sure it wasn't a mark, and then note if it was, because that's a pre-marker or can be a pre-marker of diabetes. Okay, so you want to look at that. And then the results came back from LabCorp to the parent, and if the parent said or gave consent, it would go to the primary care provider as well for follow-up. Okay. So what did they find? And again, this is just on 5th grade. Well, I gave numbers on screened for the others. But so this project was so impressive to me. So it ran 19 years, just finished recently, and they're trying to get it back in a different way. But 19 years, after the 3rd year, it was on the state line budget. It was a line item in the budget for the state. More than 20,000 kindergarten students, 99,000 5th grade, a little over 1,000 ninth grade, 91,000 second graders, and 444 eighth graders were screened. And that's incredible. So we did not have a state surveillance. And this, again, is in a time in the late 90s when no one was doing this for kids, particularly the fasting lipids. So no one knew what was going on with the kids. And West Virginia had it. And so I'm very proud of that piece, that this project gave us that. In terms of the overall stats, 18.7 of our kids were overweight. So that's over the 19 years. Of course, that increased, but overall, an average. 28.4 were obese. So if you combine that, which I should have done, 16, so about, 36, 46%, a lot of our children are either overweight or obese on average. In terms of having any abnormal lipid, so whether it was HDL, LDL, any of that, insulin, glucose, a quarter of our kids had some abnormal lipid. That was amazing and worrisome, but amazing. And then for the AN marker, 5% of our kids had AN. If you look at this by risk, by county, okay, you can see, and these are very busy, but pick a county that you're interested in, of course. So the red, similar to those BMI charts, the red is the most prevalent. Of course, you know, near my hometown, you know, this is the belt that always has the high risk factors. So it was great that they were in Boone County from the start and stayed the whole 19 years. Raleigh County is my home county. But look at all the purple, and that's 25 to 29% were obese. And even the lowest, or at least 20% of our kids. For hypertension, some similarities in counties in having the higher, or like a third or more kids with hypertension. Again, the purple, 20 to a quarter overall had hypertension. Some counties had far lower, okay, based on the screening. So this is AN, the pre-diabetes marker, okay, so a lot more purple here, but still a couple reds that had more than 10% of the kids having a pre-marker for diabetes, okay, and then any abnormal lipid, you know, again, more oranges and reds in the southern part, but still northern as well, and a lot of purple. So this was a statewide issue. It quickly went from a surveillance project, which is let's see what we have, to a, okay, what are we going to do about it? This is obviously an issue. We, I would propose, can easily as a center be in a very similar situation where we don't know a lot of the answers. We don't have a lot of the prevalence rates for PICET, you know, disability or risk factors for certain things or service utilization. And once we know that information, the next question is going to be, what are we going to do about it? So we need to be ready. That hit the cardiac project and became an important element from its, I'd say, 5th year on to the 19th, and it started a new intervention component. Okay, so when I started, of course, I'm a data geek, and I want to know a little bit more, and of course, what I shared with you is I wanted to know more about parental influences and what was going on in the home and what was the school environment like. Well, I mean, what if we wanted to intervene, what are we looking at? And so we started this additional survey that would go home after the screening took place. They had to consent again because it was an option. They didn't have to fill out an additional survey as part of it. So it's a lifestyle survey. Not everyone wanted to, and we're going to talk about that, but it went on from 2004 to 2010. And in that, we asked more questions about medical limitations. That's where we get information about children with disabilities. But I'll say right now that we didn't look at that as close as we should. Physical activity efforts being done, healthy eating habits, family efforts to live healthy, and then parental influences. So that was a bigger thing as part of this survey. Okay. So the deeper look is now looking at the, instead of looking at all 19 years, let's look at 5th grade students for that particular time period, okay? And if we look at our numbers screened, so this is all proportion of 5th grade students in the whole state that were screened for cardiac. We usually were slightly less than half throughout this period, okay? And we did comparisons that was that half maybe worse off in terms of risk factors than the other half, and there were no differences. So it was just kind of seemed to work out that way. The orange is overweight, okay, over that period, and this is for all 5th grade, and then obese kind of creeped up to the 3rd and then went down, but no big increase. All right, for lipids and AN, the yellow is the HDL, so abnormal HDL, less than 40 across the years. Here's the proportion of 5th grade students screened who had abnormal. Green is AN, and it shoots up to 27.5 that last year. I think that might be a mistake, but I'm checking on that. And then LDL kind of stays around 6.37% of the population screened. Okay. HOMA, which is kind of a diabetes measure, and insulin, these are the percentages or proportion of those screened who had it. And again, in that 2008-2009, we tended to have a peak in HOMA, which is insulin and glucose combined for that. But a lot of kids had abnormal HOMA levels. Okay. So from our deeper dive or our questionnaire, we have a much smaller sample. So from the 20,000 plus kids screened, or actually in 5th grade it's about 70,000. We had 457 who completed that survey. So just know that. That is a limitation, right? Of that 457, the percent who noted at least one disability was about 11.4, or about 52 students, okay? So much smaller. But the intent was, remember, at that point in time when we did this, thankfully we asked the question, but the intent was not to separate and compare these at all. We're doing this now, but it definitely wasn't the intent. So if we compared the kids who completed the survey, whose parents completed the survey, who had disabilities, that's in the orange, with those who did not report at least one disability, look at how the risk factors change, okay? This is very similar to what we know from the adult literature, that adults with disabilities have greater risk for cardiovascular risk factors. And sometimes they're 5-fold, okay? But it's very hard to find anything on kids in comparisons. So similar to the adults, we see increased percentages of the kids with disabilities, 25 versus 18.7, for instance, were overweight. A third versus 28 of kids without disabilities were obese, and a third were hypertensive versus 25% of those kids without disabilities. Similarly, any abnormal lipids, while it wasn't as significant, 28% versus 25%, with kids with disabilities having a greater risk of abnormal lipids. And then AN was a higher prevalence. Okay. So what does this tell us? So I'm speaking the praises of cardiac, right? West Virginia was one of the first ones to look at cardiovascular risks in kids, and many people thought that was crazy, but it wasn't too crazy when the results started coming in. Cardiac started looking at the fact of why we need to look at these things in kids and what could happen if not prevented. They also, so what do we do next? Started all of these new programs for kids with cardiovascular risk factors of any age. Okay. Problems. Okay. While cardiac was established for all kids, it really in practice did not get as many kids with disabilities, right? And I'll give you some examples. Does everyone know how to get an accurate weight on a child in a wheelchair? Does everyone know how to get an accurate height on a child with a disability, depending on that disability? Those things were not incorporated in education like the blood pressure were, and could be even now. But this is the first time we've looked at it, okay? So while it wasn't excluded, it wasn't included consciously either. Okay? And same thing for the interventions. The interventions were focusing on increased physical activity at home, increased physical activity in schools. And I don't know if you've ever seen this, but you see the kids in wheelchairs, you see the kids who might need adaptive physical activity over on the side of the gym while everyone else is doing the program. So we can do a little bit better with that and raise awareness. Okay. What our findings show is that if we don't, if we can only do one thing, we need to do, provide more interventions for kids with disabilities because they have greater risk factors. And again, that includes educating providers, educating families, and educating school and communities on what would be needed. In terms of some of the treatment options, some of those might be the same. An example, one of the big barriers for, and parents can be the barrier, is saying the common statement of, well, he has a lot of meat on his bones. He'll grow out of it if it's a child. And that doesn't tend to happen. I mean, some of it does, but not for when you're talking about obese and some of the things like that. Some people will say, well, that's genetics, and have this kind of fatalistic piece about what am I going to do about it. Some of it is genetics based, and so some of the things I included here were some of the cool things that came out of it. And are we doing this for kids with disabilities as well? So some kids, and I'll give an example, it was a 5th grade, and she's now graduated and married. She was a student here, but 5th grade student who ran cross country, healthy weight, wouldn't know anything was up, had a cholesterol of 260. So that, if you have cholesterol levels, HDL, LDL at certain levels, then you start thinking, okay, this might be genetic because they have really high levels. So then you also start to think, okay, which parent has it? Now these parents, their kids were 5th grade. They're young. They're probably not even screening themselves for high cholesterol. Again, because the societal piece was older. That's later. So this reverse screening option came about where then you screened the parents and you figured out the parent was probably not getting treatment for an extremely high cholesterol level. And so lipid clinics were started to kind of refer those families, family counseling, things of that sort. Sometimes now in the literature you're seeing these questions of statins are excellent for some kids in terms of particularly the genetic predisposition. But what kind of effect do you get on being on statins for so long, since childhood? So that's what we're looking at. And just another interesting fact that I always love to hear the story was, our heritage in West Virginia came a lot from Scotch-Irish heritage with the mines. Where we see similar patterns of cholesterol issues is in Scotland and Ireland. they have the similar rates. So you can directly map it back to our heritage in many ways of these genetic predispositions. But that doesn't overtake our lifestyle modification. And so multidisciplinary weight loss approaches, and of course doing it in the right way so that you don't develop or support an eating disorder, particularly in older kids. For kids with disabilities, teaching, asking our teachers to go through these workshops that they have more now on adaptive physical activity plans, talking to communities about adaptive physical activity opportunities, and then of course continuing to be healthy role models is important. This is another one that we could do that I think is definitely pertinent to kids with disabilities and kids in general. So, there's so much time, there's just so much time in the school day, and we're looking at schools to do everything. And so PE class was one of the ways that kids would get physical activity. But now, high school, you'd get it, well, it depends. Sometimes you get it in 9th grade, and then you don't get it at all. And the 9th grade is like one term of it. We know girls tend to decrease physical activity in middle school, and that's when we start to see PE opportunities. So one way to combat that is that the teachers are learning more about these active academics. So you can learn math while standing up. Really what we should be doing instead of us sitting down talking about this is to do, standing up, moving around, learning about math, jumping up and down. So they have different activities that they can do. You don't have, you can be in a wheelchair, you can work on upper body. You can move around and get that aerobic capacity going without doing like shuttles and things of that sort that used to happen in PE. And we know from other research that the more aerobic capacity or aerobic activity that you can do during school, the more oxygen to the brain and the better kids do on standardized test taking and tests in general and behavioral in the classroom. Behavioral issues reduce. So incorporating that will help. I included these resources, and this will be available on there with the active links. This is for kids in general, and then there's some adaptive pieces through here that talk about physical activity as well as dietary guidelines to do it the right way. And then I wanted to give a shout out to our own nutrition services program in particular. We have a website, a web page that talks, it's really good. I was double checking it and making sure that it's referencing it the right way. It's very thorough, and I think it would be a really good resource for people, as well as tips on how to measure height, weight, wheelchair accessible scales, things of that sort. And then if you don't know, the center, we do have health and wellness as an area of emphasis. And we will be providing, over the next few years, providing more and more resources on healthy eating and physical activity, and as well as stress reduction for people and kids. So with that, does anyone have any questions? And let me switch it back. Very quiet.
Hey, Les, I got a question.
Yeah, Jen.
In the beginning, you were talking about assessing children, not based on BMI, but based on where they are in percentile for weight and height.
Mm-hmm.
How does that account for muscle? I'm just thinking about, my daughter who's very tall for her age, and she is, she falls above in the height part, at least, and I'm sure for weight as well. She's always right on the very tippy top of the line for the normalized curve. So.
Yeah, and it doesn't account for muscle. So things like some people say that waist circumference is actually a better measure of risk for weight, you know, like because the most at risk is if you're the, what is that, pear-shaped, if you're carrying most of the weight in the middle.
Mhm.
So if waist circumference is increasing, you kind of want to watch that, and then they have criteria. But yeah, BMI percentile, particularly the weight percentile, does not factor in muscle. You'd have more weight because as you are more muscular, more weight would be registered, and then it's a ratio kind of deal. So that would always kind of tip you over a little bit. Yeah. So you want to. Oh, go ahead.
Would you advise that, you know, like as children enter middle school, should they be having a complete CBC and fasting glucose, like once during that time frame in middle school?
I think if you have a family history, and again, you know, the parents are young, right? So our grandparents often don't talk about it. I mean, we talk about sugar more than cholesterol in families in general. So, but if you know that there's a family history of premature heart attack or stroke or cholesterol, even, I would recommend that.
Thank you.
You're welcome. Any other questions? All right. Well, with that, thank you, Anastasia. Let's see. With that, we'll finish. But we'll be sharing this more. This was something that we had proposed for AUCD. So we'll share this. And again, you know, I think Roger was on here. Yep, Roger's on here. So, you know, we have the libraries, and we have access to families who might want more information about this. So we're going to build up our resources so that people can give recommended information out. So more on this later. But thank you very much, and have a good day.